Good evening, everyone. Good evening. Welcome to the 23rd postgraduate training program initiated by Ampok. So today we are discussing a case of gallbladder malignancy. So the case will be a CA gallbladder, but the discussion will be around an abdominal malignancy. It varies from people in Kerala. Gallbladder malignancy is not that common, but in some other parts of the country, especially northern India, it's a very common malignancy. So sometimes PNB students, depending upon where they're getting the center, you might be exposed to a CA gallbladder also. So that's the reason why we thought will discuss something different this time. Today we have two examiners who have been experienced examiners who have been working in the GA department also, Dr. Sujay and Dr. Anup. I request the examiners to take over the proceedings. Over to you, Dr. Sujay and Anup.
Yeah, so I would just like to invite the presenter. He can introduce himself, and also for discussion purpose, since we have limited time, let's stick to the case presentation and examination for the first 20 minutes, and then we divide the next 20 minutes for the early GB setting and the late or the advanced case in the last 20 minutes, the management part. So the presenter.
Yes, sir. Good evening, respected examiners and organizers and all of you. Myself, Navneet Agrawal from Amrita Institute. Sir, should I start the case?
Yeah, sure now. Is it okay, Dr. Anu? We divide this 20 minutes so that we cover adequately all the three
sure.
parts.
Yeah.
So, a 62 years old female from Ernakulam, a homemaker, came with the chief complaints of pain in the right upper abdomen for last 3 months. As stated by the patient, she was apparently well 2 months ago when she started having pain in the right upper abdomen. The pain was insidious in onset, dull aching in nature, non-radiating and non-progressive. There was no association with food intake. Pain used to get relieved spontaneously. She had continuous dull aching pain for the last 3 weeks, for which she had taken over the counter painkillers. She had loss of appetite. She lost about 5 kg weight in the last 3 months, and her weight became 58 kg from 63 kg. There was no associated vomiting or fever. There is no yellowing of eyes and no dark colored urine. There was no generalized itching in the body. There is no change in the bowel habits. There is no melena or hematemesis. There is no distension in the abdomen, and there is no blood in the urine. There is no history of jaundice in the past. There is no cough or breathlessness. There is no headache or seizures. In the past, she does not have any comorbidities. There is no history of hepatitis, no history of multiple blood transfusions. There is no past surgery, and in the family history, there is no history of malignancy in a first or second degree relatives. Menstrual and obstetric history. Her menarche was at the age of 13 years. She attained menopause at the age of 50 years, 12 years ago. She gave birth to 4 children, full-term normal delivery. Personal history. She's a never smoker, non-alcoholic, and she takes a mixed diet. Sir, is this okay?
Okay. So can you just summarize your history and give a brief idea what you are thinking of?
To summarize, a 62-year-old female came with the complaint of right upper quadrant pain for the last dull aching right upper quadrant pain for the last 3 months, which is continuous for the last 3 weeks with no association with food intake and no radiation, and with a weight loss, with a history of weight loss. So I suspect that there is some pathology in the involving the right upper quadrant, maybe the liver, biliary system, or the pancreas.
Why did you say pancreas?
So because pain is there in the right upper abdomen, so pancreas could also cause that pain.
Where would be a typical pancreatic pain? How is that pain typically?
So it's a like sharp shooting pains, or like sudden onset severe pain is there. But this patient is having dull aching pain. So
Do you typically say a pancreatitis pain? Let's say an inflammatory etiology of pancreas and a patient comes with a pancreatitis. What is the pain like? Is it in the right hypochondrium? Navneet, we'll move on fast. You
yes,
can
sir.
answer yes or no, and I'll just answer. So
No,
typically,
sir.
pancreatic pain is epigastric. It radiates
Yes,
to
sir.
the back. The patient says that the pain is relieved on stooping ahead, like that, right?
Yes, yes, sir. Yes, sir.
So rather than pancreas, any other organ which would be higher up than pancreas, and in which situation in pancreas would you have a right hypochondriac pain, a right upper quadrant abdominal pain?
Sir, in pancreas, if it involves some lesion is there in the head of the pancreas.
And it causes a biliary duct obstruction then, right?
Yes, yes, sir.
That situation. Other than pancreas, any other organ which you think will cause a similar pain in the right upper quadrant?
There is a some pathology in the colon, in the hepatic flexure of the transverse colon, in
But
the
you
hepatic
didn't.
flexure.
But do you think that kind of pain will come without any alteration in bowel habits? You didn't say any such history.
No, sir. There won't means there will be associated bowel
A much
abnormality,
a
and
much more a much more plausible organ which causes right upper quadrant pain, weight loss.
gallbladder can be there, sir.
You
Uh,
already told liver gallbladder. One more
yes, yes,
organ.
sir. Liver, gallbladder.
Duodenum,
Yes, sir. Duodenum can be there.
a peptic ulcer of the duodenum can cause similar symptoms, right?
Yes, sir. Peptic ulcer and gastritis also can cause the symptoms.
You are saying that this is a biliary or a liver pathology. Did you ask for any history of biliary colic?
No, sir. She did not have any previous colicky pain in the past.
You have to explicitly mention that in your negative history. That why is that important?
Sir, because if there is a there could be gallstones which could periodically cause the colicky pain in the biliary colic if they lodge in the bile duct, common
Yeah.
bile duct.
And what would that gallstones be? You know, risk factor for?
Gallbladder, uh, chronic colitis, this gallstones can cause gallbladder cancer, are a risk factor for gallbladder cancer.
Right. So you have to ask for biliary colic. Okay. Any history of biliary colic on the preceding years? Because almost uh, all cases of gallbladder cancers, like around 70 to 90% of these patients will be having history of gallstones. It is in the setting of a gallstone that a GB cancer comes in these patients. So many of them will give this history of biliary colic in the preceding years. Okay.
Yes,
So
sir.
what is that biliary colic history typically?
Sir, biliary colic is like patient will complain of sudden onset pain, and it will be last in the mainly in the right upper right hypochondrium, and will be lasting for about 1 hour or more, and it radiates to the shoulder region. So
Exacerbated by what?
exacerbated it mainly after eating fatty meals. It exacerbates.
Yeah, correct. Okay. So your differentials at this point are hepatic or a biliary pathology.
Yes, sir.
Any
Hepatic.
hepatic pathology that you have in mind?
Uh, sir, could be hepatitis and or
Amoebic liver abscess.
Maybe yes, liver abscess could be there. Amoebic liver abscess could be there.
So
And
you just have to, at this point, at least from the history, you cannot say that this is a malignancy. Can you say that it is a malignancy?
Sir, one factor which favors malignancy is the weight loss. Like she had in last 3 months, she lost about 5 kg of weight. So that is one factor which may point towards malignancy, but we cannot confirmly say what is the pathology at this stage.
Is this weight loss significant?
Sir, actually, she lost 5 kg. So uh, the in last 3 months. So we significant we could say in 6 months if she lost 10 kg of weight. So it's around about
It's not 10
10%.
kg. Yeah.
So it's about 10%. So not we cannot surely say it's significant. Maybe over time she would have lost more weight. We could not.
Sure. But even a duodenal ulcer with can cause that kind of a weight loss. Okay. So you just have to keep differentials of biliary, liver, duodenal in this situation. Okay.
Yes, sir.
Why did you ask for symptoms of vomiting?
Sir, vomiting could be there if there is any obstruction and means the duodenal pathology could also cause vomiting, and if there is a mass which is means a gallbladder also could lead to vomiting if there is uh, any stone is impacted, or that could cause vomiting when pain is there along with so to rule out any GI upper GI obstruction or pathology and fever.
Dr. Anu?
Navneet, yeah, Navneet.
Yes,
So
sir.
your first differential diagnosis in this patient is gallbladder cancer or biliary tract malignancy, is it not?
Sir, we cannot means at this stage I could not say anything for
Oh,
sure what is the
okay.
differential
So
based on.
what all history? What is the importance of asking past history in patient with a patient suspected of a biliary tract cancer or a gallbladder malignancy? So what all things will you ask in the history pertaining to the biliary tract cancers?
Sir, for biliary tract cancer specifically,
Specific questions you will want to elicit from the patient.
if there is any history of typhoid, because in the endemic regions, typhoid typhoid is one of the risk factors, and which could chronic typhoid infection can is a causative factor uh, for gallbladder cancers, and
Then ask for the history of any
and
cholelithiasis. Ask for history
yes,
of any history that's suggestive of cholecystitis. Okay, so
yes,
importance of cholecystitis. Then ask for the typhoid history because chronic typhoid infections can precipitate is a strong risk factor for biliary tract malignancy, especially for gallbladder. Then you should always ask also for the history of primary sclerosing cholangitis.
yes, sir.
Then ask for the inflammatory bowel disease. So any history of inflammatory bowel disease in this patient. Because IBD patients, inflammatory bowel disease patients are more, some patients are more prone to have primary sclerosing cholangitis. So these patients can have, certain patients can have, can lead to biliary tract malignancies. Then
Yes.
ask for the history of any polyp. Okay.
Yes. Yes.
Yeah. So what is porcelain gallbladder?
Sir, porcelain gallbladder is calcified gallbladder. So that is also,
What is the importance here?
sir, because porcelain gallbladder is also can transform into malignancy over time.
So
That is also.
if we ask you history of porcelain gallbladder, so is it a high risk, or is it a moderate risk, or is it a low risk?
Porcelain gallbladder is a high risk, sir.
It's a high risk. Whenever you have a porcelain gallbladder, that's a high risk for biliary tract malignancies. Then, whenever you have an increase in size of the stones, that is also high risk for getting biliary gallbladder cancer.
Yes.
What is the importance of asking family history in this patient?
Sir, about 10% gallbladder cancers can have a germline mutation involving BRCA genes or
So what
BRCA
BRCA?
ATM.
Which BRCA is associated with the gallbladder cancers?
Both 1 and 2 are involved.
Yeah, among the 1 and 2, which is most common?
1 is more common, sir.
No, it is BRCA2. So what are the other malignancies where BRCA2 is associated?
Sir, ovary and breast.
Then
Breast, ovary, pancreas,
pancreas,
and prostate.
prostate, and biliary tract malignancies. Okay.
Yes.
Then what are the other familial or hereditary symptoms which can be associated with?
Lynch syndrome and
Lynch syndrome.
Lynch syndrome can be associated.
Yeah, that is associated with it. Continue.
Go on to your examination.
On examination, patient is well oriented to time, place, and person, having a performance status of 1, height 162 centimeter, weight 58 kg, BMI of 22 kg per square meter, and BSA of 1.61 square meter. She was examined in the presence of a female staff in supine position with adequate exposure. BP was 114 bar 74 mm of Hg, pulse was 80 per minute, respiratory rate 13 per minute, and SpO2 99% on room air. There is no pallor, icterus, clubbing, cyanosis, or generalized lymphadenopathy. CNS, CVS, chest where examination were within normal limit. On local examination, the abdomen was flat, umbilicus was central and inverted, all quadrants were moving with respiration, striae marks were present, there is no dilated veins, no visible peristalsis or pulsations, no fullness seen, no cuff impulse present at the hernia sites, and genitalia were normal. On palpation, abdomen is soft, non-tender. There is no local rise of temperature, no guarding or rigidity, and inferior border of liver is palpable up to 1 finger breadth below the right costal margin. And well-defined globular mass is felt in the right hypochondrium. It is firm in consistency with smooth surface, measures about 5 into 5 centimeter. It is below the right costal margin, reaching up to 4 finger breadth inferiorly, and it moves with respiration. The lateral, medial, and inferior borders are well defined. You cannot reach over the upper end of the mass. Um, there is no other lump palpable. There is no supraclavicular lymph node palpable. On percussion, a dull note is present over the lump. Tympanic note is present over rest of the abdomen. No shifting dullness. Liver span is 14 centimeter in the mid-clavicular line. And on auscultation, normal bowel sounds are heard. Per vaginal and per rectal examination are normal. Bilateral breasts are normal.
So what is your clinical diagnosis in this patient after your local examination?
Sir, I could palpate a mass in the right hypochondrium of about 5 centimeter, and with
Yeah, you already described everything in detail. So what is your diagnosis?
so the diagnosis is a gallbladder mass.
So you are suspecting what? It's a gallbladder benign pathology or a malignant pathology in this patient?
Sir, probably this is a malignant pathology.
Why you say so?
Sir, because of the features of the features of the mass, which is firm in consistency and like enlarged in size, and like we cannot get over the upper end uh, of the mass. So probably there won't be
Navneet,
an
these palpatory features are in favor of what? Benign condition or a malignant condition?
sir. Sir, because this is the uh, smooth surface, and so we cannot really differentiate between because benign and malignant, because the surface
We
is
just say
smooth.
where these features are more in favor of which? Benign or malignant? Question is simple. More in favor of which?
More in favor of
Instead of
ben
firm consistency, you should have got a hard
art.
consistency. You should
Yes,
have got a nodular surface, right? Just because you
yes,
cannot
yes.
get above the swelling doesn't mean that it is a malignant condition. Unable to get above the swelling just tells you what?
So that it is in continuity with the above structure like liver. So
Yeah.
means the
So that doesn't
the
so
it
that doesn't
extends above.
differentiate. Yeah, that doesn't differentiate benign or malignant. Okay.
Yes, sir. So this is more in favor of a benign pathology.
So, what
Let's
benign
see.
pathology is associated with loss of weight and loss of appetite from your history? So, your patient has got a significant weight loss and appetite, loss of appetite.
Yes.
So, you still consider some benign pathology in this patient?
Sir, we can consider like based on combined history and examination. So possibility of malignancy is not ruled out. So we will still consider the uh, malignant
But you are
pathology.
more in favor of benign pathology, right?
Sir, based on the palpate means the
No, as a
palpatory
full.
findings. As
So
a full,
after
sir,
the
I'm
clinical
uh,
examination, history and clinical examination, you should have a diagnosis. Yeah.
yes.
Okay. So what is your final diagnosis in this patient? Clinical diagnosis after a history and clinical examination. That is my question.
Sir, the differentials will include carcinoma,
So what
gallbladder, the
differentials
top.
you need? Whenever you get a patient with a gallbladder mass, what differential you want to take?
Sir, first will be carcinoma, gallbladder. Second will be uh, xanthogranuloma,
Carcinoma gallbladder.
xanthogranulomatous uh, cholecystitis. Uh,
What you say? Second is
xanthogranulomatous cholecystitis, sir.
xanthogranulomatous cholecystitis. How can you say that it's a xanthogranulomatous cholecystitis after a clinical examination? What is xanthogranulomatous cholecystitis?
Sir, it is a benign condition.
And how you
With the
diagnose xanthogranulomatous cholecystitis?
sir, it's like features are generally indistinguishable from the.
Can you diagnose with the clinical examination after your clinical examination and history?
No, sir.
Then
But
how can you say that the second differential diagnosis is this xanthogranulomatous cholecystitis? So you have a real case, you have a straightforward case with the gallbladder cancer in front of you. Then you
yes.
should say like that. Okay, your first and second differential diagnosis, see a gallbladder, rather than taking to some other places.
Yes, sir.
Okay. So suppose this patient is having a jaundice. So this patient doesn't have any jaundice. So you have a gallbladder cancer with a jaundice. So what is your inference? So
Sir,
after your clinical examination, this patient is having a jaundice with a gallbladder cancer. So what all informations are in your mind in such patients?
sir, if this is a gallbladder then with a jaundice, then probably it indicates an advanced stage disease. So
Very
there
good.
could be multiple possibilities that a gallbladder cancer is in extending into the common bile duct, and maybe there is a lymph nodal involvement which is compressing upon the bile ducts causing the jaundice. And
Yeah. So whenever
uh,
you get a gallbladder with a jaundice, it gives you an idea that you are dealing with an advanced stage disease. It's not a simple disease. Okay, first one.
yes,
Second is, this patient is going to have a very poor outcome. Second.
yes,
Okay.
yes,
Then third is, this patient is having a very low resectability in the scenario.
yes,
Okay.
sir.
So
Yes,
whenever you have a jaundice, it's very bad disease, very advanced. It's not going to cure by surgery, and this patient will live only for a few months. So this is the impression whenever you get a jaundice in a patient with a gallbladder.
yes, yes, sir.
Okay. So what are the other presentations of presentations in gallbladder cancer?
So the patient can be presenting asymptomatic and incidentally diagnosed gallbladder cancer can be there at the time of surgery for uh, cholecystectomy, or maybe a routine ultrasound abdomen
Yeah.
can for any other cause can pick up CA gallbladder. So other
So
How many
present,
cases worldwide present as incidental gallbladder?
there like I
Can you
don't
give
know the exact.
give a brief number?
Sir,
Guess?
I guess like around 40%, sir. 30 to 40%.
Fair guess. 2/3 of the cases of early gallbladder cancer are detected incidentally. In India, it is around 35 to 40%.
Yes.
And
Navneet,
Yes, sir.
yeah.
yeah,
So
so
there you can
just one more
continue.
point.
Sorry.
Yeah, just one more point. When the thing that I was asking about, how do you justify, or how do you say the palpatory findings which are more in favor of benign with a history which is more in favor of malignant? Uh, there is one situation where you can defend that. Can you say which gallbladder cancer, which in which part of the gallbladder will this presentation be there? On palpation, you get a smooth, uh, firm lump, which is not hard or nodular, but at the same time, it's a malignancy on history.
Uh,
There is one location in gallbladder where the presentation can be like this, and that is one way where you can defend your findings and history.
sir, if it is in the fundus, then
No, no, not fundus. If it is in the gallbladder
whole
neck,
body neck. Okay,
okay?
sir. Yes.
Yeah.
Yeah. So we were talking about presentations, right? So
Yes, sir.
you are discussed about presentations. One is all these patients can present with obstructive jaundice. Some patient can be present as an incidental finding on whenever you take an ultrasound or a CT. Then
Yes.
it can present. It can sometimes this may present as a mimicking cholecystitis. Some patients can present as a mimicker of cholecystitis.
Yes.
Then you can sometimes you get while uh, examining the pathological review for cholecystitis. So these are the different presentations of gallbladder.
Yes.
Yeah. So Navneet, you go on to the, you have this patient where you are suspecting CA gallbladder. How would you go on to manage the case?
Sir, so with this, first I would like to do the diagnostic investigations. So I'll,
What would be the first test that you do?
sir, I'll do the tumor markers in the blood. Other than the routine blood investigations, I'll go for CEA, CA19-9 at least in the tumor markers, and then
Navneet, hold on. You said you would first do the diagnostic investigations. Will the tumor markers and this be a part of the diagnostic workup?
Yes, sir, they will be part of the diagnostic workup, but they are not specific for this, but they will help in the diagnosis. So,
Okay, fine, fair enough. So investigations to establish the diagnosis, and then there will be investigations to proceed ahead with the treatment. So in that you can talk about the routine blood tests and the tumor markers, but investigations to establish the diagnosis, which will be those?
sir, first I'd like to get a ultrasound abdomen, and because uh, this will give a baseline fast investigation, and we would get to know the organ of origin, uh, and uh,
And one more thing.
it would because it would tell us about gallbladder stones also, and also it will tell us about malignancy also. uh, USG can tell us about malignancy also in the gallbladder, if there is a specific features like asymmetric wall thickening. So with these
Okay.
features, yes, sir.
Yeah.
And it will tell
So
us
if
also
on an
about the
ultrasound,
IHBRD.
yes,
Also,
IHBRD stones, if there is a mass like situation in the gallbladder fossa and also any parenchymal liver mets, these can be easily seen on the ultrasound. Okay.
yes, yes, sir.
And if you see on an ultrasound, just that there is a thickening of the gallbladder mucosa, which is around 6 mm. There is no mass as such seen. Can this be a malignancy?
Sir, if uh, could be a malignancy, but it has to be like asymmetric thickening. So and
Uh,
also polyp.
asymmetry would favor malignancy, but asymmetry is not always necessary. Even when there is no asymmetry within the thickening, within the cholecystitis, chronic cholecystitis that is there in the gallbladder, uh, you can have a CA gallbladder. That is how incidental gallbladders are detected, right?
Yes,
When patient is undergone a simple cholecystectomy for a apparently cholecystitis, and then on histopathology you see an invasive malignancy. So there on your pre-operative radiological imaging with ultrasound will not show anything that is suspicious of malignancy. A simple thickening can also present with a malignancy. Let's say there is an irregular thickening, not uniform thickening, tumor markers are raised, then what would you go on to do?
sir. Then I'll go on for a CT scan, contrast enhanced CT scan of abdomen, pelvis, at least, and with chest also.
All the options are
Hello,
Yeah.
sir. CT, chest, abdomen, and pelvis, and
Okay. Preferably a triphasic,
with
a good
contrast,
contrast CT scan of the abdomen pelvis. Sure.
and
And
uh, otherwise,
on the CT
other.
scan,
Yes, sir.
let's
Hello.
say on this CT scan, you see a suspicious gallbladder thickening, which is suspicious for malignancy. There are also regional lymph nodes which are present in the hepatoduodenal ligament. Uh, what would you do next? And let's say the surgeon says it is a resectable disease.
Yes, sir. So, uh, sir, like if the CT, chest, abdomen, pelvis has been done, then this is uh, enough for, and we should do laparoscopy, I mean staging laparoscopy before.
Before that, would you do an FNA biopsy?
No, sir. If we are planning for upfront surgery, we'll not do a FNA or biopsy.
Why?
Because it would lead to peritoneal seeding if along the track of the biopsy. So
One reason is that,
when,
and another reason is even if you do an FNAC and it comes as negative, it does not mean that it rules out malignancy. Okay.
yes,
So
sir.
in either
Suppose you are
situation, yeah.
suppose you want to a surgeon wants to take this patient for NACT.
Yes, sir.
Yeah. Now, in this situation, if the surgeon says that can't operate but want to give NACT,
So sir, in that
would you
case,
do the field biopsy?
we have to do a biopsy, preferably core needle biopsy, if should be
Why?
done. Because sir, then we will be sure about the pathology, histopathology, whether it is means what kind of tumor we are dealing with. Majority will be adenocarcinoma, but there will be other pathologies also. And
Which
uh,
which pathology do you want to rule out for the management?
sir, means there could be very rare cases of like it could be neuroendocrine also, and
Yeah.
could be so.
Yeah, it
Based
can
on
be
that,
neuroendocrine or small cell. Yeah.
so based on that, we have to decide the chemotherapy, and also uh, we will be having a chunk of tissue. Uh, means our diagnosis will be confirmed beforehand, so that is
Okay.
important.
Role of
When
PET
the-
scan?
Sir, PET scan is not fully established, but it will upstage about 1/4 of the patients in the uh, early stage, and 1/3 about 1/3 in the locally advanced cases. So if PET scan is available, it should be done.
What about
Yeah, it
MRI?
can change.
Sir, MR,
Navneet,
yes, sir.
what about MRI in this patient?
Sir,
What is the
MRI,
uses of MRI in gallbladder cancer?
sir, MRI should be used to plan the surgery, and in case if there is a jaundice, we should do the MRI, because the liver resection plane has to be decided, and the extent of resection has to be decided based on the uh, involvement of the biliary tract. So that will help us in deciding for the surgical decisions. So that is.
So, in conclusion, CT or MRI basically used in gallbladder cancer is one is to diagnose, locate the tumor, then evaluate the tumor, then evaluate for the extent of the nodal disease, then tumor invasion to the adjacent organs, and of course, presence of metastasis, and also penetration of the tumor to the wall of the gallbladder. So we can identify all these criteria whenever you go for an imaging in patient with the gallbladder cancer, right?
Yes, yes, sir.
Navneet, can you tell me on CT, what all features would contraindicate surgery?
Sir, in CT scan, if there is uh, involvement of nodes um, beyond the porta hepatis, like in the celiac axis or the retropancreatic nodes. Uh, so means outside. So
Not
or
exactly
the
retropancreatic. The
or
celiac, superior mesenteric, or the para-aortic.
paraaortic. So
You
if
start with distant mets.
yes, sir.
Okay,
Means
any
if there
distant
is
mets,
any distant mets is there in any organ, or if there is
any visible
any
peritoneal disease,
any visible peritoneal disease, or any distant lymph node metastasis, or if there is a in the liver also, if there is disseminated mets or extension beyond, or if there is means basically these are the criteria for unresectability.
liver infiltration beyond what is technically unresectable.
Sir, 4A 5 segment 4 and 5, if it goes beyond that, so it will be unresectable.
Okay.
So in which all cases you need a extended hepatic resection in patient with the gallbladder?
Sir, if extended hepatic resection in curative setting, we will do if the by there is no adequate margin, means 2 centimeter at least is needed, 2 to 3 centimeter. If that cannot be attained in view of the tumor in the liver, means then we need a hepatectomy. So ideally we should take a 2 to 3 centimeter margin, or complete formal resection of segment 4 and 5. And if it extends beyond, means we can do a right hepatectomy also.
Okay,
If
so
the
what
function,
is the
yes,
what is the the surgery for your patient?
Sir, surgery will involve there will be 3 steps. One will be the extended cholecystectomy. Second means it will be involving the liver resection. Means segment
What is
4 and 5
extended cholecystectomy?
means this is
Is there
the
a word like
means
extended cholecystectomy?
we'll do the we'll remove the gallbladder. We will remove the segment 4 and 5 of the liver, or some surgeons say we should remove at least 2 to 3 centimeter uh, around with a margin of 2 to 3 centimeter, and we should do the lymph node dissection. uh, that should be done.
So what all lymph nodes dissection you have to done?
Sir, in the porta hepatis, the nodes we should dissect retroduodenal and gastrohepatic. Sir.
Gastrohepatic ligaments. Okay, very good. So will you go for bile duct excision?
Yes, what, sir?
Bile duct excision. Will you go for
Bile,
bile duct?
sir, bile duct excision is not routinely recommended, but in certain conditions, we can go for bile duct excision in the conditions where if we are going for means there is a lymph node which is adherent to the bile duct, and we need to remove the lymph node for the resection, and it is not means it is adherent, so in that condition we should remove. Or if the tumor is involving the bile duct, in that condition we should do the bile duct resection. Otherwise it is not routinely recommended.
Okay, good.
Cystic duct margin positivity, even that whenever it is there, intra-frozen section, if it comes out as the cystic duct cut margin is positive, then the surgeons would go on to do the extrahepatic bile duct excision. Okay.
Yes, sir.
We have to get the negative cystic duct margin in that scenario.
Yes, sir.
So Navneet, let's say this is an incidental gallbladder case. A general surgeon operates upon the patient, does a simple cholecystectomy, and the pathology says it is PT1B.
Yes, sir.
What do you do? The
So,
patient
sir,
has come to you.
yes, sir. So because this is a incomplete surgery has been done in this patient in view of the incidental diagnosed gallbladder cancer, so we have to plan for the completion surgery of this patient. So for that, if the staging workup we should do before proceeding for the completion surgery. So ideally PET scan should be done. Yes,
How
sir.
many weeks? PET scan should be done after how many weeks of the initial surgery?
The surgery revision surgery should be done as soon as possible. There is but means whenever the patient comes, as soon as possible we should take up the patient for the revision surgery. Means or we can give at the most 4 weeks gap from the last surgery.
Navneet, suppose your patient underwent a simple cholecystectomy and patient is HPR is T1A in 0M0. Will you go for revision surgery in this case?
No, sir, that surgery is complete in itself. So we not need any.
So any tumors more than T2 has to go for revision surgery. Okay.
Yes, sir. T1B also, sir.
T1B also. T1B also.
Why so? Do you know why so?
Sir, because in T1A it will involve only the mucosa, but in T1B it will spread beyond the mucosa. So means it will
beyond the mucosa, meaning which layer?
Lamina propria. Sir.
T1B is what?
T1B is muscle layer.
Muscular. Yeah. So what happens?
So, sir, there is a chance of spread outside the gallbladder. So we should means and also involving the liver could be there. So we should do the completion surgery.
10 to 20% of those cases of T1B will have a residual disease either at the primary or in the nodes, regional nodes. And that is why you should go on to do radical cholecystectomy with lymphadenectomy, T1B and above. Okay.
Yes.
Suppose you don't. Suppose you are suspecting a gallbladder cancer and the diagnosis is not clear. So you want to take this patient for surgery.
Sir, means a new patient means we are suspecting
new patients.
we are suspecting gallbladder cancer and we want to take for surgery.
Not clear, but you have to go for surgery. Then what you do? You have to go for frozen
So
sections, frozen biopsy to
yes,
confirm the diagnosis. Then you can proceed with the definite resection.
yes, sir.
You have resected
Suppose-
the tumor, done the radical cholecystectomy. How many? What is the minimum number of lymph nodes that should be removed?
Sir,
Any-
six lymph nodes should be removed at least.
6 nodes removed, 0 out of them involved, and it's a T2 lesion. Now, what do you do?
Sir, then we'll go with the adjuvant treatment, sir, with this patient, for this patient. After that,
What adjuvant treatment?
we'll give the capecitabine, single agent capecitabine for 120 1250 mg per meter square BD for like 2 out of 3 weeks for 8 cycles.
As per which trial?
Sir, bill cap trial.
Any other agents which has been shown to be positive in the adjuvant setting other than capecitabine?
Uh, gem gemcitabine cisplatin, sir, and
Is there a positive study for gemcitabine cisplatin yet?
no, sir.
No, there is no study till now which is positive for gemcitabine cisplatin. But many of the centers in India do use gemcitabine cisplatin as adjuvant. The other drug which I was talking about was used in Japan.
Yes.
Do you know?
Sir, S1.
Yeah, it was the ASCOT trial. Okay. Any trial ongoing which is evaluating gemcitabine cisplatin compared to capecitabine for adjuvant? Do you know the name of that trial?
No, sir.
It has completed recruitment. The name of that is Actica 1. So probably that trial will answer the question whether gemcitabine cisplatin can be used as adjuvant or not. Okay.
Okay, sir.
There was a trial of Gemox compared to gemcitabine, which came out to be negative because of statistical reasons, although numerically the survival was much better with Gemox. That was Prodigy 12. That was a negative study. But because the Gem Platinum arm showed a much higher survival, that is why many of us in India still use gemcitabine cisplatin. Also, taking data from the metastatic setting.
Yes, sir.
And that trial was a ACCOT trial also. That was also a gemstone based regimen where there was no survival advantage in the adjuvant setting.
Okay, sir.
So when you will go for chemo radiation,
Sir, chemo radiation will go if it is a node positive
indication for
disease.
chemo radiation.
Node positive disease or margin positive, sir, in this condition will go for chemo radiation, sir.
More so for
So suppose you have an R1
margin positive. Yeah.
you have an R1 positive, will you go for chemo followed by CTRT or CTRT followed by chemotherapy?
Sir, CTRT followed by chemotherapy, sir.
You can do either way, chemotherapy followed by CTRT, or you can do CTRT followed by chemo also.
Okay, sir.
When do you use neoadjuvant? Do you use neoadjuvant in gallbladder cancers?
Yes, sir. We use neoadjuvant. Actually, if it is, if we feel that post chemotherapy the disease could be resectable, in those condition we use neoadjuvant, and also in conditions where it is a poorly differentiated tumor or
Can you
poor
list
biology,
no,
aggressive biology, we should use.
can you list some criteria where patients can be taken up for neoadjuvant and not upfront resection?
Sir, if
T and some vessels.
uh, yes, sir. So, if it is uh, T3 tumors, T3 and above, we can take up for neoadjuvant T3 and N1 disease. And if there is a jaundice present, uh, in these conditions, we can take up the patient for a neoadjuvant and then consider for surgery based on response.
And also, if the major vessels, there is a less than 180-degree impingement of the vessels like hepatic artery, portal vein, if there is a liver infiltration which is beyond 2 centimeter, T3, T4, these are situations where you can go for neoadjuvant followed by surgery. Okay.
Yes, yes, sir.
Which are the regimens used for neoadjuvant?
So neoadjuvant, we can gemcitabine, cisplatin, and durvalumab is the one regimen, and gemcitabine, cisplatin is another one, and gemcitabine,
Then
oxaliplatin.
you can go for FOLFOX or HEPAX also.
Okay, sir.
For
There was
advanced,
a paper in JAMA of triplet. It was a phase 2 study. Do you know which triplet?
Sir, gemcitabine,
Triplet chemo.
cisplatin, durvalumab.
No, triplet chemo.
I don't know, sir.
So, okay. It was Gemcis Nab-Paclitaxel for locally advanced biliary tract cancers. Around 18% of them were gallbladder, but it was Gemcis Nab-Paclitaxel. Are you aware of any study of triplet versus doublet in the advanced setting, metastatic gallbladder biliary tract cancer? The same group of investigators who did that phase 2 study in locally advanced did a triplet compared with doublet. Are you aware of that study? It's okay. It came just about a year back. It was SWOG 1815, where Gemcis was compared with Gemcis Nab-Paclitaxel. It was in biliary tract cancers. It was an overall negative study. Negative study in that the survival was not different, but in the subgroup of gallbladder cancer, the survival was actually double, 9 months versus 17 months. So probably the gallbladder cancer, maybe a triplet regimen can be used, which someone has to do a phase 3 study and prove for the gallbladder group per se. Okay.
Yes, yes, sir.
what are the studies for advanced disease, advanced gallbladder cancer?
Sir,
Metastatic.
ABC trial, ABC02 trial.
Yeah.
Which
What is ABC 06 trial?
sir, it compared gemcitabine alone versus gemcitabine and cisplatin in advanced biliary tract cancers. So that had a significantly better outcome survival with gemcitabine cisplatin compared to gemcitabine alone.
What is the median survival you get with the chemotherapy alone in patients with the advanced metastatic gallbladder cancer?
Sir, in metastatic advanced, about 1 year, sir.
Okay, suppose you're adding immunotherapy to the chemotherapy, like in Topaz trial.
Sir,
What is the survival?
like
What would the median survival increase by?
sir, around 1 month.
Not 1 month. About 1.8 months.
Okay, sir.
If you talk about the percentage surviving at 2 years, Gemcis versus Gemcis Durva, do you know the proportion? That is one other way where patients are counseled.
No, sir.
On the Gemcis arm, it is 10% versus 25% on the Gemcis Durva arm at 2 years.
2 years. So
Any
because
other
So what is seen in the Topaz trial was in those patients who had chemotherapy and versus chemotherapy at 12 months, at 1 year, the survival was almost similar. The survival benefit was much seen after 12 months of durvalumab. So continuation after 1 year, up to 1 year, after beyond 1 year has shown a benefit in Topaz trial basically. So responders did well in patient with Topaz trial.
Yes.
Any other immunotherapy study in the same setting?
Sir, I don't know the name of study, sir, but
Keynote.
Which drug?
but NevoEP is also used.
No.
No.
Similar
What?
to
Keynote trial,
Topaz one,
phase
but
3.
bro, keynote 966. Similar results. Instead of 10% with Gemsys in Topaz, it was 18% versus 25% at 2 years for Gemsys versus Gemsys Pembro. Keynote 966. That is the second immunotherapy trial in the first line setting for advanced biliary tract. Okay.
Yes.
The
Would
nivolumab
you
was in the
like to
second
do
line.
an
Yes, sir.
Yeah.
Nivolumab trial was in the second line phase 2 trial.
Sir, I could not hear.
Nivolumab trial was the second line trial. Second line. What you have mentioned is not in the first line.
Okay, sir.
That was a phase 2 trial.
Yes, sir.
In an advanced setting, would you like to do some molecular test?
Yes, sir. Would like to do, sir.
Which?
Sir, HER2 testing, sir. HER2, FGFR testing, IDH. At least these 3 should be done. And if we can get NGS, like there are multiple targets which can be there, but their percentages are very less, like less than 5% are there. But maximum we can see HER2, FGFR, and IDH1 mutation in which are having at least 10% in advanced. So this should be at least done, tested.
What
10%?
percentage of HER2 is positive in
Yes, sir.
biliary tract?
Sir,
What is the percentage of HER2 positivity?
about 25%, sir. 25.
Yeah, up to
That's high.
30% you can get positive HER2 positivity. You can get in TRK positive. Then what about MSI? Do we need
Yes, sir.
MSI or MMR?
Yes, sir. We should do MSI and tumor mutation burden also, so that we
Yeah.
can.
So whenever you have an advanced biliary tract cancers, you have to go for, that's an indication for comprehensive genomic profiling.
Yes,
Okay,
sir.
so the commonest mutations are HER2, then it is followed by, you can get an NTRK, you can MSI high patients, then you can get red positivity. Okay, you can get BRAF positivity. So all this has got specific agents. So
Navneet,
doing
if you
an
do an
NGS
NGS,
is,
Yes, sir.
sorry, if you do an NGS, may not be targetable, which is the most common mutation that you are likely to find on that NGS? Which gene
KRAS
mutation?
mutation.
And
KRAS and other
P53.
P53. Yes.
Yeah. And for HER2 in gallbladder, are you aware of any study where trastuzumab was used in the first line with chemo?
No, sir. I don't know about the trial.
and there is an Indian study.
Indian study.
Yeah. That was in I think last year also.
It was a single arm phase 2 study where Gem's trastuzumab was given. And they saw that with addition of trastuzumab, there is an improvement in survival as compared to those patients who screen failed and did not take trastuzumab. So that was a phase 2 study. They are going to do a phase 3 study. Okay.
Yes, sir.
It was an Indian study which was presented last year.
Okay, sir.
In that, if someone asks you what was the percentage of HER2, that it was around 13-15%. HER2 positivity in gallbladders.
Okay, sir.
Okay.
Yes, sir.
Any other questions, Dr. Anup?
No, nothing. We can wind up actually.
Yeah, okay. Last one question just about epidemiology. This is a bonus question if you can answer. Like throughout the world, which are those areas where endemically gallbladder cancers are higher as compared to other biliary tract cancers like cholangio?
Sir, in India, the region around the Ganga river, northern India, so
One,
means
North India.
eastern
Yeah.
UP and Bihar, and another one is the South America, sir, Argentina, Chile, uh, these areas,
And one
and
more area.
sir, Northern Africa, sir, uh,
East Asia.
East Asia. Okay, sir.
East Asia, Southeast Asian countries like India. Within India, do you see a North versus South divide?
Yes, yes, sir. There is in North India, the incidence is around like 10 to 12 per 1 lakh population, whereas in southern part of India, the incidence is like 1 to 2 per 1 lakh. So it's like
Yeah.
uh,
Correct. It is 10 times higher in the North India. Is there any reason for that? Any
sir,
plausible reasons which have been mentioned?
sir, there are multiple reasons because along the Ganga, one reason could be the pollution, the chemicals pollution, which could because the river Ganga is the primary source of water in those areas. So one reason could be the contaminants, and the another reason could be the uh, endemicity of chronic typhoid. Like typhoid is prevalent in that part of India, so
Okay.
that is also a risk factor. So that is there, and another is mustard oil is also said to be one of the causative agent. So maybe
One another
that
toxin.
aflatoxin is there, sir. Aflatoxin is there, which is known to cause, but
Yeah, correct.
no, not-
Female to male
Navani,
preponderance.
Sir, female is more common than male. Overall, male is more common, but in northern part of India, the female is more common than male.
No. Females are overall more common in for GB cancers. It is 2:1. Overall, GB cancers 2:1 for females.
Navani,
Yes, yes.
recently there is an increase in cholangiocarcinoma and biliary tract cancers in southern India also. What is the reason for that? What is the etiology? Most likely etiology. The incidence is coming up in southern India also. Especially in Kerala also, we are getting so many patients with cholangiocarcinoma nowadays. What could be the reason? You have discussed about the reasons in the northeastern region. What could be the reason in southern part of the India which is coming up? The incidence is coming up. Why?
Sir, practice.
The reason is
Not
for,
sure.
yeah, it is due to diabetes, metabolic syndrome, and non-alcoholic fatty liver disease. So that this is considered to be a high risk factor for cholangiocarcinoma and biliary tract malignancies. So that is the reason why we are getting higher cases of cholangiocarcinoma. It's metabolic syndrome. NAFLD.
Yes, sir.
Okay.
Yes, sir.
So Jay, we can wind up.
Yeah, we can wind up. Yeah. Thanks,
Okay,
thanks, Dr. Navdeep. You
Yes.
really presented and answered well.
Thank you,
Good,
sir.
very good.
Thank you, sir.
Okay. Thank you, Dr. Sujay and Dr. Anup. We had a very excellent discussion. I think like it's a very rare malignancy. I mean, at least in South India, it's a very rare malignancy. But then most of the aspects concerned to the disease has been discussed. So I feel like all the postgraduates who joined would have definitely benefited out of this session. So thank you all. So we'll catch up next month with a different case. So see you. Good night.
Thank you.
Good night.
Thank you, sir.
Dr. Navdeep. Thanks.
Thank you, sir.